Okay, so we've had a very lively discussion and I think more to follow. This is part of the same spectrum. This was a randomized phase 3 study of Gefitinib versus adjuvant chemotherapy, that is Cisplatin and Vinorelbine, for patients who had stage 2 to 3A NSCLC who had an EGFR mutation. So in short, we know that as of now, adjuvant chemotherapy in NSCLCs, Cisplatin doublet is standard of care based on data. We have approximately 5% overall survival benefit, mostly 2 to 3A and select stage 1B patients. We also know that quite a few number of these patients do eventually recur. And when it comes to EGFR disease, we know EGFR TKIs work wonderfully well in the advanced setting. So the question is basically that, how can we improve outcomes further in, say, this particular subset of patient population? So this trial also tried to answer this question. So it was a multi-center, open-labeled, randomized phase 3 trial in Japan. Went on till 2015. They took patients with stage 2-3 NSCLC with good performance status and either tumors with exon 19 deletion or L858R mutation. One underwent complete surgical resections, either lobectomy or pneumonectomy, and mediastinal nodal dissection. They were randomized to Gefitinib, 250 mg once daily for 2 years, 24 months, or Cisplatin, 80 mg per meter square, plus Vinorelbine, 25 mg per meter square, day 1, day 8, every 3 weeks for 4 cycles. And they were put under follow-up. There was MRI and PET-CT follow-up in this particular study. The primary endpoint was disease-free survival. Secondary endpoints were overall survival, safety, recurrence, local versus distant, and adverse events. So the consort diagram in short, around 234 patients were randomized, almost similar numbers in each arm. And eventually around 115 were treated with Gefitinib and 115 were treated with chemotherapy. Out of which rate of completion of 4 cycles in chemo arm was good. It was around 78%, and 61% of patients took Gefitinib for 2 years. And this is the kind of the little table where they've shown why they discontinued. So the point here is that almost 19 patients relapsed while they were getting treatment on Gefitinib, as opposed to 2 patients who relapsed or got a second cancer in the chemotherapy arm. So in the end, similar amount of patients were alive, and mostly death was due to relapse. Coming to baseline characteristics, almost similar in both the arms. This is a very busy table. Grossly, most patients had nodal disease, which was positive, N1 and N2, and around 65% patients had stage 3 disease. Now coming to the results, data was cut off in 2020, nearly 2021, in December. Median follow-up was 70 months. And if you look at the DFS curves, they started to cross around 4.5 years. And DFS and OS were not really significant between the two arms. Coming to subgroup analysis, so almost all subgroups, there was no apparent difference, except that patients who were more than 70 years of age tended to do better with Gefitinib. However, this was a very small patient population. And this was an exploratory analysis. Safety, as expected, more chemotherapy-related neutropenia and febrile neutropenia. More grade 3-4 toxicities in the chemotherapy arm to the tune of nearly 90%, as opposed to 42% in the Gefitinib arm. Gefitinib, more diarrhea, more rashes, more mucositis, but eventually grade 3, grade 4 toxicities were less. There was no ILD reported in this trial, and there was an increase in ALT seen in almost 25% of patients, which was grade 3 or grade 4. 3 patients died in the chemo arm, none in the Gefitinib arm. So coming to the relapse sites, almost similar between the two arms, except for brain. So the CNS rates of relapse were actually higher in the Gefitinib arm, around 30%, as opposed to 18% in the chemotherapy arm. Coming to subsequent therapy that was received, crossover from chemotherapy to TKI was to the tune of around 80%. Crossover from Gefitinib to chemo was around 35%, and later on in second, third lines it became almost 52% patients who received chemo. What I couldn't find in the paper and even the supplementary article, the appendix, was that how many of them actually received EGFR TKIs, the third generation TKIs, osimertinib. So this is a question that I can't answer as of now. The authors concluded that Gefitinib as post-op adjuvant therapy for patients with resected stage 2-3 NSCLC harboring EGFR mutations was not beneficial in prolonging DFS and OS. Platinum doublet therapy should remain the standard of care, followed by adjuvant osimertinib where available. And for select patient subsets with contraindications to this approach, adjuvant Gefitinib could be considered as an alternative. However, they also wrote that this is not powered as a non-inferiority trial, so they don't really know whether that equivalence to chemotherapy or TKI is there or not. To discuss, we are going to have this discussion again. We've had this discussion in the prior two slides. So there are multiple trials which have looked at EGFR TKIs, first generation EGFR TKIs, out of which I've highlighted the ones that had chemotherapy as the other arm. So mostly all these trials, they show very good DFS benefit. Okay, I'll just stop quickly. However, as we've also discussed previously, with the DFS benefit also starts waning after the TKI is stopped. So the recurrence rates start rising. This was seen in almost all the trials done so far. And there has been no OS benefit which has been seen. What else? ADAURA, we know that there's a fantastic DFS benefit, which was again reported in ESMO 2022. Again, post-recurrence, there seems to be some data post-stopping osimertinib that recurrence rates are starting to increase, including CNS recurrences. So for this particular study, discussion point-wise, well, doesn't seem to be a lot of role of Gefitinib per se in the adjuvant setting for EGFR TKI. We would want to wait for OS data for third generation EGFR TKIs, would want to define which of these subpopulations will benefit, maybe do a study in geriatric patients more than 70 years. And ma'am, I'm looking at you. And of course, find biomarkers, look for MRD, ctDNA, so go in that direction now. And duration, as we discussed, we have to define. Thank you.